Thank you. So you all know already that I'm not David Mower. I'm not sure I'm Peter Doshi either, given the weird jet lag I've been having since I came. But let's get into the story here. The story of today I'm going to tell you is about Tamiflu. And as with all Cochrane Views, it's not a one-man show. We're a team of 7 right now, led by Tom Jefferson, and our group really spans the entire globe: Australia, UK, Japan, Italy, and me in the US. We should start the story in 2005. Tamiflu came before that, but the story really starts in 2005 because it's at that point that governments around the world began to stockpile Tamiflu in great quantities. This was, of course, because of the concern about bird flu, avian influenza, the H5N1, the great pandemic that was coming. And the evidence base at this point looked a little bit like this. There was a Cochrane review, the same one that I'm working on now. As you know, they always go through constant updates. And the update at 2006 suggested that Tamiflu would be effective in reducing the complications of influenza, especially bronchitis and pneumonia. That was the conclusion. This conclusion was relatively consistent with what you saw in national guidelines in the US and other countries. So for the US, the Centers for Disease Control and Prevention wrote that Tamiflu would reduce the risk for pneumonia by approximately 50%, and that was based on 10 clinical trials. Same study found that there would be a reduction in hospital admissions. This study cited is the Kaiser 2003 analysis. And you should remember that name because it's going to come up in this talk again. This was the evidence base. The United States Pandemic Plan, this is the national plan, hundreds of pages, and it had as a critical assumption that Tamiflu would again reduce the risk of pneumonia, decrease hospitalization by about half, and also decrease mortality. So they stockpile. No citation was given in the document that I just showed you. However, in the previous year, there was a draft pandemic plan, and that had more specific details. It said that there was, again, 10 randomized placebo-controlled studies, 3,591 adults and adolescents. That didn't have a citation either. However, the numbers that are cited are identical to what you find in the Kaiser 2003 analysis, so it's pretty clear the evidence base came from Kaiser. Something then soon changed in 2009. H1N1s, the swine flu. Everybody's now worried. Tamiflu is being, rushed out of the warehouses. And our Cochrane review is now scheduled for an update. This was actually funded by the UK and Australian governments who needed rapid assessment of an important medicine in a dangerous time. And then this man on the right, Keiji Hayashi, a Japanese pediatrician, wrote to the Cochrane collaboration and challenged our review. He said, I have a few problems with what you guys have concluded. And this was, again, looking at the 2006, which was then present. He said that, your entire review is based on the Kaiser 2003 paper. That drives your conclusion that Tamiflu would reduce the complications of influenza. But Hayashi had a few problems. He said, first of all, that Kaiser paper is a Roche-authored paper. Appeared in the Archives of Internal Medicine, and it's a pooled analysis of 10, again, Roche-funded RCTs. And then he said, but only 2 of those 10 trials have ever been published, and 8 of them are not published. And that is the same today, hasn't changed. So he said, I think you need to verify these data for yourself. And so we took that challenge upon ourselves. And the evidence was missing. So what would you do? This is what we did. We contacted the authors. We'd like the data. We have to answer a question from Dr. Hayashi. Professor Kaiser says, well, I suggest you contact Roche directly. Professor Hayden, who's also on the Kaiser paper, says, well, he searched for the files, which is nice of him, but he can't find them. Okay. And if you want original data, you'll have to go to Roche. So we're bounced to Roche by Professor Kaiser and Hayden. John Trenner is the lead author of one of the two published papers. He doesn't return our emails. Carl Nicholson is the lead author of the second of the two published studies, and he also reports not being able to give us the data. We should contact Roche. Simultaneous to this, the BMJ is running an investigation. And so they're contacting Professors Trenner, the JAMA article, and Professors Nicholson, the Lancet, and asking them about the data too. And Trenner states that I did not perform an independent analysis of the primary data, which was not required or requested by JAMA at the time of submission, and I do not have access to the primary data, which I also never requested. It's a lot of important info there. Take your time to read that. Nicholson reports that he did not recall seeing the primary data, that the statistical analysis had been done by Roche, and he had only seen the summary data. So he's the lead authors. The largest treatment trial of Tamiflu, which goes by the code M76001, this is the totality of the evidence in the public domain. It's a paragraph, proceedings from a conference abstract. The lead author is given as John Trenner, same as the JAMA paper. But Trenner reports that he didn't actually participate in the study and doesn't remember going to any conference to present this paper. So let's pause and think, what's going on here? What is the role of trust in the scientific publication process, and what does this story have to say about that? And what's the role of trust in evidence synthesis, the work that we are doing? And do the named authors, the people who have their name on the journal article, do they have a responsibility to provide data that allows for an independent verification of claims? And for our immediate business, what are we to do after not getting any data after trying? What are we to conclude? Well, we conclude the only thing we can conclude, which is that we don't know. We can't say whether the drug Tamiflu reduces the complications of influenza. We don't have the data to say yes or no. And that was published in December 2009. At the same time, and in the same issue of the BMJ, Roche makes a historic claim. I don't know if anybody heard the claim from GSK yesterday about they're going to open clinical trial data. Well, Roche was first to get there in a fantastic claim. Full study reports will be made available to the investigators in the coming days. And it's very happy to have its data reviewed. What's a full study report? We didn't really know, but we asked for them. Here's a table of contents of one of these clinical study reports. And you can see it includes things that you would find in a journal article, the IMRAD, introduction, methods, results, and some extra documents like the study protocol and the amendment history, a blank case report, so the randomization list, certificates of analysis, the statistical analysis plan, that's what the reporting analysis plan is. Lots of documents. Fortunately, that's all Roche gave us. No full study reports. And that remains the case today, even though we asked for it for, I don't know, about 8 times over a year and a half. But something was happening within our group, which is an evolution of understanding about the types of data. Yesterday, Steve Goodman asked, what is data? And I think that's a question we really need to be thinking hard about. Anybody who's involved in evidence synthesis, what is data? What are the types of data? And this gives you a schematic, a little similar actually to Liz Wager's diagram yesterday, about the types of documents that will be created in the course of doing a clinical trial, like a protocol or case report forms. And then that goes into what I would say some kind of bank of all the recorded history of a trial. And then through some kind of unclear process, which isn't that apparent to anybody on the outside, you get things that come out of it. And we're used to looking over here. But what we now had a glimpse of was this unpublished domain, the clinical study report. And so this might help you understand how we started to see the world of evidence in a different way. That's Tom Jefferson, of course. And so he's out looking for all the evidence he can find. Above the waterline are your public documents. And so, lo and behold, he found a trial. And what he gets when he looks at the trial is the journal publication, and maybe if he looks really, really hard, he'll find something in the gray literature like that conference abstract. But below that, for the very same trial, there's all these other types of data. There's those case report forms, there's the clinical study report, big, and there's electronic patient level data, individual patient data, sometimes called IPD, and I think incorrectly referred to often as raw data, as if that's the only type of raw data. And then you have all that same type of information for trials that were never published. And so they go completely invisible to us. So we decided we need some new methods to deal with what we're looking at. And I just want to highlight the two key ones. We decided we wouldn't synthesize any information from published papers, and instead would use the clinical study report as our unit of analysis, in addition to looking at regulators' comments, like reports the FDA medical officers would write. That's what I mean by regulatory material. So from going from not having any data to 3,000 pages of incomplete case clinical study reports from Roche, we then got closer to 20,000, and that's because the European Medicines Agency changed its rules on access to documents in November 2010 and said, if we have it, you can have it. Of course, they might black out some bits, but in the case of Tamiflu, they didn't black out anything. And so we received 22,239 unique pages over around 24 trials that we requested clinical study reports on Tamiflu. There's one for you to see, get a sense of what it looks like printed out. And I always, calm down, that's double-sided. (8,545 pages. Just so you have a sense, what is this kind of document? So we read through them. And reading through them, we found out things that we wouldn't have found if we were only dealing with, oh, by the way, this is that's that study I just showed you. Here it is in the published literature, 7 pages. So we found out things like in the JAMA trial that was published by Trenner, it's reported that there were no drug-related serious adverse events. However, in the clinical study report, they mentioned 10 serious adverse events, of which 3 were said to be possibly related to Tamiflu. So you find discrepancies like this. Just to give you another example, in the section that held the certificate of analysis, which is what an independent laboratory, they take the actual interventions used from the batches that were used. They take the capsules and they say, what was in it? What did it look like? What was its size? So on and so forth. And it's recorded, and this is the record. And you see the Tamiflu capsule had a light yellow cap, whereas the placebo capsule had an ivory cap. Now that's not apparent in this paper, where they talk about it just as a placebo, nor in the body of the clinical study report, the 200-page long beginning, where they call it a matching placebo. And so our conclusions changed. Just looking at the clinical study reports, no publications, we concluded that there's no decreased risk in hospitalization, no evidence it can stop transmission of the virus, and in fact there was suggestive evidence that Tamiflu interferes with natural influenza antibody production. I want to end with this. I brought you from 2005 to 2012. But if we wind the clock way back to when Tamiflu was approved first in the US, 1999, Roche produced promotional materials. And in it, they claimed, this is the promotional material, and in it they wrote that Tamiflu reduces incidence of secondary complications, i.e. bacterial infections, by 45%. The FDA saw this, and they wrote them an official warning letter saying you cannot say this, you must cease saying this, because it's not supported by substantial evidence. This was known since the year 2000. Since that point in time, the Tamiflu product label has stated that serious bacterial infections may begin with influenza-like symptoms or may coexist or occur as complications. Tamiflu has not been shown to prevent such complications, that's still on the label today. Yet we stockpiled with all those assumptions of that exact same benefit. Why? Thank you.